Hi, I'm Wendy Garp-Lipp from United Neighbors, and this is Inside Fall River. I'm delighted today to welcome three guests to talk about the prescription monitoring program. First, we have Representative Carole Fiola, who is from the state representative from the 6th Bristol District. Welcome, Carole. Glad to have you.
Great to be here.
And we have Len Young, who is an epidemiologist from the Department of Public Health. Glad to have you, Len.
Thank you. Nice to be here.
And Jean St. Pierre, a certified redirection therapist and substance abuse counselor. Welcome,
Nice
Jean.
to be here.
Today we're going to talk a little bit about Massachusetts prescription monitoring program. But before we get to the program itself, can you tell us what is the issue and how do we affect it? How are we affected here in Fall River?
If I could start, Wendy, first I want to thank you for having us on your program, and really first give some credit to Jean St. Pierre here, because all of the viewers know that we've been talking about this incredible epidemic we have, not only nationwide, statewide, but in our own community, and that is opiate addiction, and that's heroin and other level 2 category drugs, Vicodins, Percocets, and those other. They've become pervasive. They've been wreaking havoc, this addiction issue, throughout our community, the Commonwealth, and the nation. I, as a pretty new state representative, serve on a committee called Mental Health and Substance Abuse, and have had the opportunity to work closely with the Department of Public Health. And we've started, and there's been an uproar, of course, and an outcry about what do we do about this epidemic. While I've been out visibly talking about this issue along with my colleagues, Gene, who's a citizen of the community, has been in recovery for much of his life and active in trying to come up with solutions to this problem, contacted me. And together now we've been working, myself, the other colleagues that I work with, Rep. Sylvia, Rep. Schmidt, but here in Fall River and throughout the Commonwealth to try to figure out how we can be of help. Along the way, I became very involved and aware of this prescription monitoring program that we're going to talk about. And as I said, I work closely with the Department of Public Health, and this is actually the Department of Public Health's third visit down here at my invitation to Fall River. We had the Associate Commissioner down on a round table with all the hospitals and health centers and public safety officials and treatment providers. And then we had them back again to visit with a practicing group of physicians. And now Len has come, an epidemiologist, has come down to talk and perhaps educate our viewers on what this prescription monitoring program is, how it can be helpful to this epidemic, and what it means to the viewers out there. And Len, thank you.
So before we get to that point, let's just set the stage. What is the problem? Tell us what the epidemic is. What are you seeing in the state of Massachusetts, in the nation, and specifically in Fall River?
So the nature of the epidemic, it's very multifactorial. There's basically we have prescription medications that are they're either painkillers or other types of controlled substances, and these are frequently prescribed, and people who are receiving them can become addicted. So that's one issue. There's also other types of drugs, heroin, and other types of opioid drugs that people take. So, and of course, that has been going on for a long time. But the prescription drugs are, more specifically, have been a problem over the last several decades and have really become an issue over the last number of years because they've been being prescribed more and more frequently, and people become addicted to them, dependent. And then what happens often is they will also turn to other types of drugs because they may be less expensive, or also because of restricted access at times. Especially over the last few years, we've been trying to reduce inappropriate access to these types of prescription drugs. So sometimes people who are already dependent on these may turn to other street drugs or heroin.
I just heard, I think a couple of days ago, about the NFL that they've come out, that players have now, retired players have come out, and they said how much they were prescribed. One player talked about playing on a broken leg for the entire season and being given painkillers and not ever knowing that he had a broken leg. So this is not just a Fall River problem.
Of course not, no. It's a national problem, and the Centers for Disease Control recently had declared it as an epidemic because of it's very pervasive throughout the country. There are some states that are worse than other states. Massachusetts happens to be pretty bad, but there are states like Kentucky who have even more serious problems in many of their areas. So it's certainly throughout the country, but we in Massachusetts certainly are trying to focus on the problem, and there are a number of tools that we can use.
Great.
And that's the prescription monitoring program.
Excellent. So let's hear, what is the prescription monitoring program?
You know, Wendy, before Len gets into that, and Jean may want to add to this, because when people are looking, they're going to hear today about the prescription monitoring program. We know, as Len said, the tools that are out there, there's a lot of pieces to this puzzle.
Right.
There is the education piece, not only to the citizens, but to the doctors, providers, to the EMTs, to the public safety, and these are the things that are getting addressed. Today we're going to focus on PMP, but we know there's education. We know there's treatment. Jean is a treatment specialist, right, Jean?
Correct. Right. I think the thing that I am very happy to see is that I've been involved in this since I entered recovery back in 1988, and back then a lot of people had their heads in the sand. We don't have a problem, it's not that bad, so on and so forth. You move ahead 20-odd years, and the epidemic is everywhere. So now they can't hide no more. And we have an administration locally and at the state level that are coming openly and saying, we have a problem, we need to do something. And I think that's a big key to this, because without their voices and people like the mayor and Carole speaking out, to give it credibility, it's just another addict's voice.
You know, Wendy, one of the things before Len turns over to really talk about how the PMP got started, because it's not a new program, but it's just become reactivated with some new pieces to it. I think we should start with what happened about 11 years ago. So maybe you could talk about the PMP and what happened when pain became a fifth vital sign, and that is really a piece of why the PMP is so important today. And you could maybe take it from there, Len.
Right. I mean, I think very simply, I don't remember the exact time frame, but as you mentioned, it was probably about 11 years or so, where there was kind of an evolution of treating pain, and I think there was a lot more emphasis on that. There were new drug products that came out, because many, if you go way back, we didn't have all these different opioid products. We didn't have OxyContin. We didn't have Vicodin. But these drug products came out over the last few decades, and more of them came out as they became, the drug companies, they were obviously profitable for the companies, and they certainly are effective. And what also happened, I think, is that a lot of the prescribers were being more and more evaluated based on the treatment of pain. So they, patients often would have to come in and fill a survey. Did you, adequately, or did the doctor adequately treat your pain? So, so that, that kind of pendulum swung over quite a bit, and it certainly, I think, that's kind of what precipitated the trend in abuse and dependence of a lot of these opioid drugs.
I think for a long time people thought that drug abuse had to be heroin, cocaine, crack, methadone, and all of a sudden it's our family members that are addicted to these opiates, and it's not somebody in the street sitting somewhere, someone that you think, oh, I have no connection to that person. It's our children and our parents and our neighbors and our friends.
Sure.
So have you found that there's been a change in the way people perceive the problem because of the education that we've been putting out there?
I think you're seeing it now more because it's home now. It was, if I can make a reference, it was kind of like when Magic Johnson came out. People said, wow, it can happen to an athlete, a real person,
Right.
And now we know that whether you're poor, rich, doctor, lawyer, your child, or even you, could be affected. I think maybe it's not accepted, but I think the more we bring it out and the more people that come out and speak about it that are of credible status, I think, people are going to catch on and say, we got a real issue. You're always going to have them naysayers, but we can't worry.
I credit Chris Herron from our own Fall
Right,
River.
from our own.
There you go.
Our
Talk
good
about
friend,
credibility.
Good
Chris
example.
Herron, he really, I think, sparked that credibility. You look at a vibrant, handsome, smart, someone who had everything in front of him, lost it all,
Yep.
but yet rebounded, and now he tours the country, as we know. I think he gave us that,
Absolutely.
Another piece of that credibility.
Absolutely.
Right, but I also think we have to give credit to people like Jean,
Oh, yeah.
who come and speak from the heart about your own experiences.
Would you do that in the past? Would you feel uncomfortable, Jean, in the past saying, I am in recovery, I was an addict in my other life?
I think the people that know me know I'm not afraid to say what's on my mind. So I have done it in the past. I think I have never felt more comfortable about it, though.
Than you
to
have
answer that,
recently.
than recently. I mean, I think you can be in recovery and still be not a nice person. I think it's a whole package you have to work on, and it takes years and years and years. I mean, coming from being a heroin addict and eating Oxycontins and you name it, it's not easy. It's not easy. You still get pains, you still have accidents, you still get broken bones. What do you do then?
That's right.
Right.
It doesn't end because you enter recovery. You need to keep working every day at different things. You fall down, you break a leg, and you're an addict. What do you do when the doctor says, here's 30 perks or something? You say, hey, doc, sorry, keep them. Give me the Tylenols. And not everybody.
That takes strength of character and strength of soul
fear,
to be able to
fear
do
of
that.
relapse.
Right.
I think fear of relapse.
Right.
And that's incredible, Jean, your story, and so many stories that I have heard since we've been talking about this issue in the last several months even, and people come to me every day with that story, and so we encourage you to let you know you're not alone. So now that's a great segue.
Right
Because you
into-
talked about what do you do when a doctor hands you a prescription. Talk about the PMP, what it is, how it works, and how it can be helpful to people.
Sure, and I actually just wanted to speak to that point about in terms of it impacting all demographics as well, because that's really important.
Right.
And I think the fact that these prescription drugs now that are so widely available, they're not just available in the cities, or they're not just available in rural
Right.
areas. They're available everywhere, and that's really that's why I think it is such a pervasive epidemic, that it doesn't affect just one demographic area.
So PMP, Prescription Monitoring Program.
So the prescription monitoring program, it actually has been around since the early 1990s. But as Representative Fiola mentioned, that over the last several years, it has transformed and undergone a number of changes. One of the biggest ones is the operation of the online PMP. What we refer to the online PMP is actually the ability for providers. So
Doctor.
doctors,
Hospital, dentist.
well, not hospitals, but so doctors,
Individuals.
pharmacists, and also we allow certain types of law enforcement to actually access the online PMP, and they can look at a patient's prescription history.
It's a database.
It is a database.
So
correct.
I'm the patient. I come to you, you're my doctor. I say, oh, I have terrible back pain. Can you prescribe something for me? What happens then?
What should be the first thing that happens?
Well, so if the doctor is considering prescribing a controlled substance, they would actually go online, and it's secure. It's a secure site, and only that prescriber has access. Every prescriber has authorization. They have to enroll. It's a very secure system. But they would go online and they would put in the first name, last name, date of birth of that patient. And then the information would come up for 1 year. So it provides the anything that patient has been prescribed if it's a controlled substance. So things like if it's an antibiotic or heart medication, we don't monitor that. But if it is a controlled, what we refer to as a Schedule 2 through 5 controlled substance, then that would be or should be in our database.
So if I'm bouncing from doctor to doctor,
I
you get to see that as my doctor.
Exactly.
And you know that perhaps I really don't have the pain. Perhaps I'm seeking drugs.
Right.
Right.
So
Go ahead.
I was going to say, so yeah, I think that is something that we absolutely, we look for is, we look for multiple prescribers, we look for multiple pharmacies. People who are going to many different pharmacies also sets off a red flag. And we do not contact the Department of Public Health, we don't contact the patients. We work with the provider community because they're the ones that they have the relationships with the patients. And that's what we try to work with them. And, you know, I think there's a lot of training and education that hopefully that needs to be done on that level as well.
So I'd like to just anticipate a question that the audience might have. Just to make sure, you said that it's a secure website, only the provider who has registered and has gone through whatever process. So insurance companies don't have access to it?
They do
The
not.
public does not have access to it? Anybody who's not your doctor does not have access to it? Okay, so
Correct.
that's really important for people to know, that this is a safe place. This is not a place for people to put information that will go out to the big community. This is a place where information is going to be to help your health and to make sure that your doctor and you can work together for better outcomes.
That's a great point, and we take that very, very seriously. That's something that, you know, we realize that this is very sensitive, confidential information, and it belongs with the authorized users, the providers.
And it all starts with the pharmacist. So once a prescription is given, it's the pharmacist that then starts everything ticking because it's entered into the database from the pharmacist.
That makes sense, because
so-
that's where it starts.
that's
right.
I can
where-
That makes
give a little bit more perspective on that. So the pharmacy, so it's basically it's the pharmacy that sends the information to the prescription monitoring program, and they report the information on a weekly basis right now. And that's one of the things over time we've actually are looking into more frequent reporting of the data. When I started a couple of years ago, they were reporting on a monthly basis. We went to weekly reporting, I believe, in 2011, and we are now considering maybe moving that to a daily reporting.
And just to show the kind of coordination that happens with the Department of Public Health, the House of Representatives, information coming from the community, we, in our House budget, and the Senate should just about be finished now, we put in money to
Continue to support this?
continue to increase so that the technology, it's time.
Right, the technology has to grow with the problem.
So we know that this is, because we know prescription drugs are such an issue, the prescription monitoring program is a tool, just one that we're talking about today. We could talk about a number of other things that will allow us to, for the providers, as Len said, to be aware. Wendy, I didn't realize. Wendy,
Right.
you know,
Do you know that you had it last month, right?
Jean, now Jean,
Right.
you're in a different situation, but Jean, you know, if you were just prescribed. You would just see you saw a doctor so-and-so.
I think
And
the
so
thing.
what is this?
I think the piece of that I grasp onto the most, coming from my perspective, is the fact that accountability on behalf of not only the patient who's doctor shopping, but the doctors. Where I believe a lot of this needs to be. I think that once people don't like change, nobody likes change, and everything's going to be fought. But I believe that at some point when it's mandatory that if you want to write this level of medication, you're going to enter this system or you're not going to write the medication. I think when we get there and when the money's going to keep coming to fund it, obviously, but when we get to that point, I think you're going to see a move on the street level, because what's going to happen is the less medication hits the street, the less people are going to have their hands on it. It's just domino effect.
Right, and we do know that, you know, someone prescribes me with a drug. I don't use the full prescription.
There you go.
And then I could take that and give it to somebody else.
Make a lot of
Or
money.
my child can take it out of the cabinet because I haven't taken care of it and brought it to the police department for
Absolutely.
disposal.
That's
so
part of the
there's
whole
right.
problem.
So it's not just the patient that legitimately gets the drug. It's what happens when you have leftovers or when you don't need it anymore.
Yeah.
But I also remember not too long ago in Fall River, I remember that there was a doctor who was prescribing, you know, 60 prescriptions in one day.
Several years ago. Yeah.
Right, several years ago. So I imagine that this picks that up as well.
Yes, it does.
Right.
We can, so we monitor obviously the patients, but we also We also routinely monitor prescribers, and also we can monitor pharmacists.
So that's
or
terrific.
pharmacies.
Right.
Pharmacies.
Right.
But the prescribers, we can look at their prescribing patterns and to see if there's extremely unusual patterns of prescribing certain types of drugs. And that is something we've done routinely for many, many years. And we have it's called a medical review group, MRG, that meets on a monthly basis, and they look at these particular cases that we identify as a team in the program, and they will determine whether they think, and this MRG comprises of doctors and pharmacists, so they can actually assess whether they think this is really unusual prescribing. And then it goes to, if they do, if they agree, then it goes to the board of medicine.
Now, is this mandatory
Yeah,
now?
let's talk about that, because
Right.
the governor, as you know, as Jean mentioned, raised this to a full epidemic.
Yep.
And the House, we're all responding to this. So now, by the end of the next licensing cycle, and actually by the end of this calendar year, doctors, providers need to be registered.
So, yeah, so we still haven't gotten a specific directive for that yet, but that is what is currently being discussed, and certainly the governor has talked about that.
You haven't gotten the final word?
We
When?
haven't gotten the
I gotta
final
talk
word
to the
yet.
governor. I thought it was the end
But-
of this calendar year.
Well, we're thinking that's probably the case, but we again
Not
we
for
haven't
sure.
gotten the final word.
So maybe I'm naive, but what would be the downside? Why wouldn't people want to register? Why wouldn't a
Well-
pharmacy want to have this
Well, we've
tracked
talked
or
to
a doctor?
providers, so we can talk about that.
For doctors and other prescribers, there are many prescribers who never even prescribe controlled substances. They have anyone who prescribes in the state has to have, it's called an MCSR. It's a mass controlled substance registration. But even though they may have it, they may not prescribe at all, or they may prescribe 1, 2, 5
Occasionally, right.
prescriptions a year. So for those people, there's nothing wrong. There is no necessarily downside to be enrolled, but they're not really the ones that are utilizing it. There are other types of specialties that simply, radiologists, for example, they really don't prescribe at all.
Right.
They'll probably have an MCSR just in case, but they don't really prescribe. So, and for those groups, they may see this as more of another
Paperwork.
another burden. So, is it a
Seems
big
small price to
But it is
pay?
for them.
for-
It's taking away what they've earned, and they've earned their credentials, they've earned their experience, so they feel it's an imposition. And you can see that piece of it. However,
Right.
the problem is too pervasive, too big.
I don't know, but I don't know if that's a justifiable answer, only because we need licensing for everything. To ride a motorcycle,
Oh, yeah, they're
you need a
licensed.
license. To be a pest control person, you need a license to carry those kind of chemicals. So it seems to me that that's sort of a weak argument,
Right.
that it's a little bit too
Kinda.
much paperwork and
It
you're...
kind of sounds to me a little bit like what I mentioned a couple of minutes ago. Nobody likes change.
That's what it is.
And by nature, people fight change. It's just the way it is.
Right. But the problem is that the epidemic has changed.
Well, let's talk about a
Obviously.
quick example, because what's going to happen is the DPH is also going to be doing a lot of education, because providers, physicians, I'll use them, physicians, dentists, they've been working at their profession for years. They learn about the drug epidemic the way we do, from the media,
Right.
on TV, from a family member or a friend. And because this epidemic has just grown so much, and the prescription piece we talked about is such a piece of it, they need to be re-educated on, Wendy's a nice gal. I've been seeing Wendy for years.
She can't possibly be an addict.
That's right. Or she can't possibly be scamming me.
Right.
And now, think about this. Because we've met with doctors, we've talked to them, specifically doctors who prescribe and overprescribe. And you know what they'll say? What do I do with Wendy? I've been meeting with Wendy and providing her with Percocets every month or every 2 months for the last 10 years. What happens now to Wendy if she has to come off those drugs?
Okay.
You are an addict now. And so
Right.
now that leads into
Am I going to get it off the street?
where
Am I
you're
going to
get
it
it.
from a neighbor? Right.
So doctors need to be trained to
Very
then
good point.
redirect people to the treatment centers, for example, the STARS, the Stepping Stone, whatever, all the treatment centers, and other options, pain management clinics. And so that's what DPH is. And matter of fact, the Associate Commissioner is going to be back talking. We're going to talk about putting together a credit program for providers down here so they come and get fully apprised of what the impact and effects are of overprescribing. So that's a piece of it.
That's very interesting.
And another component of that is it's called academic detailing, where people who have expertise in this area in prescribing, they actually go out to the doctor's offices and they work with them to see how they've been prescribing medication, controlled medications, and then determining, is it appropriate? Are there ways that they can improve it? What other things, for example, screening, drug screening, having contracts with the patient so that they are monitored closely. Those are all things that I think, when a lot of doctors go to medical school, they don't necessarily learn. So
It's interesting. I have a degenerative joint disorder, and I saw a doctor for many, many years and got a lot of painkillers, which is how he dealt with it. And recently I changed to another doctor about a year ago, and he has me swimming, and he has me walking, and he gave me an entire different way for pain management that didn't involve drugs, and I have better results than being on the drugs. And it was interesting to me that in the first doctor I saw never even opened that as an option. All he simply did was, check me out, well, this will help you, and it did help. But after a while, the dosage didn't help, and you needed a higher dosage, and I was getting worried, which is why I changed doctors.
So that's a very good point. And there's certainly a school of thought out there in the medical community where, in terms of long-term, long-acting opioids and extended time periods, that it probably is not the best practice to be on that. For short periods of time, acute pain, absolutely, they can do very, very important
We don't
things.
want to stop that. No one
No,
wants to stop
absolutely.
people with pain from getting their
You have to
medication.
remember that there's two ends to everything. We're talking about the part of the abuse and everything, but there are a lot of people that benefit from drugs too. And
Absolutely.
I don't ever want anybody to think that that's
The intent here.
my intent.
No, but it's great that I was given an option.
Yes.
And that, I wouldn't opt for surgery as the first step.
No.
Why would I opt for drugs as the first step? Shouldn't I try and opt for things that would be more non-invasive for my body? And if that doesn't work, then certainly the drug is the next option.
Well, that leads me to two quick points, and I want to get across to the viewers. You have a say in this. When I go to the dentist, and we chatted about this off air.
Right.
You're automatically, if you're getting some dental work or a tooth pulled or an implant or whatever, you're automatically handed a prescription. And you know what? You can just say no and say, I'll take extra strength Tylenol. You can do that. The doctors or dentists sometimes need to, based on their protocols, hand you that. But here's the problem, and this is where something would come up with you, Gene. You go to the doctor, they're not asking, do you have an addictive gene in your family? Are you in recovery?
Right.
Were you a former heroin user, or did you ever have a problem? And so if they're not asking those questions, which gets back to what the DPH is going to be doing with training,
Monitoring, right.
then it's easy to get slipped right back into this problem. So I encourage the viewers to take control.
So we're in the last 15 seconds. So if people want to find out more about this, I Googled it and found tons of information on the Department of Public Health website, and you can definitely contact Representative Fiola, and she'd be happy to discuss this as well. So this is a very big problem, and the only way we're going to solve this problem is more than a one-prong approach. We need the prescription monitoring program, we need education, we need people like Gene to speak out, we need community agencies to be on board, because together we will make change.
Thank
This is
you.
Wendy Garp-Lipp, and this is Inside Fall River. Thank you.
Thank you.